But the problem is they were kind of organized the way typical HIMSS department organizes information. In our legacy systems in McKesson, we had built a different way for people to find information because we basically mapped all documents to 2 locations, but one was kind of a clinically useful schema for finding documents. And we lost that when we went to Centricity, to Cerner, and it was a real challenge for people. And what perplexed me and still perplexes me is that Cerner doesn't allow you to set global filters for documents. You have to get to every end user to set filters. It seemed extremely inefficient, and we struggled with that through 2 years. And so what we did is we tackled it by trying to match what we had done in our legacy systems. So that's really what I'm going to show right now. So what I'm going to show you is actually going to also be in the workflow. So it would be actually a tab that you could go to. We haven't enabled that yet. But right now I get to this by going to this tab, Document Filters. And you can see here what we did is we lumped things together. So we had ED and inpatient, operative notes and procedures, phone notes and nurse visits, ED, advanced directives, cardiopulmonary testing. So you can see everything here, and I just got to scroll up because I'm missing the office visits. So you can see that everything's kind of organized by that. And then if you can either expand them all, class them all, or expand one at a time. But when I do this, I can see the pertinent visits here, and they're organized in a way that makes more sense to me, and I can find things more easily. And our experience to date with the end users is this has been a big win for us. And people that are really struggling finding documents now don't seem to struggle as much. And I'll show you an example. Advanced directives, we've now, after feedback from people, we've decided what to map into these buckets here. So we have pain management stuff here. We have advanced directives, portable DNRs, pulse forms. All that stuff is in one location. Super easy for people to find them. Similarly, we had a lot of problems where people were searching for cath lab tests or stress tests or whatever, and the way we had to set these filters up, it was not easy. So we've now put those things all together in one bucket. And I'll just scroll down, and I'm going to stop for a second of questions, but I'm going to just scroll through so you can see what we've mapped. Now, this isn't every document in Millennium, but it's what we find are the most important clinical documents for people to get to. So that's kind of the way we approached it. And I would say, if you want to know how it's built, the structure of this is we have a specialty document, specialty documentation in the ESH. Each one of these categories is an event set. And then what we do is we bring in the documents individually into that event set. So we can easily change this filter. If we decide, oh, there's a document we missed, we can just add it in. Or if it's a document people don't think belongs in that bucket, we can take it out. But we're doing that at a global level, and it's relatively easy to maintain. And I'll give you another example where we got a big win. We had a problem with people being able to find a lot of the basic preventative stuff. So colonoscopies, mammographies, because they're all in different locations. We put that all into one bucket now. So if this patient is only 34, it doesn't have a colonoscopy, but if it was an older patient with colonoscopies, you'd find it here. You'd find the bone densities, you'd find the mammography, pap smears, that type of thing. So I'm going to stop for a second and field some questions, but this was our solution to try to make it easier for end users to find documents, but it also simplified our training because we're not spending any time now on people setting up document filters.
So if you go back to the M page, you built this as a custom M page?
Yes.
Component. Or is it its own M page or just a component that you built off of like the M page? Oh.
It's going to be its own M page in the workflow. You know, the part of it that you're seeing right now is we have to get to it through the table of contents, but we're actually going to put it as a tab, as its own M page. So there'd be a document tab here.
Okay.
If that makes sense.
Yep. Looks amazing.
Any other questions or comments?
Well, one of the things we struggle in the offices is scanned documents.
Yep.
How did you handle that?
Well, because you map this at the global level, if it's a scanned document, as long as it's labeled, and you know, it's the problem with scanning. If people don't scan it to the correct document type, you're still never going to find it. But if it's scanned as a direct document type, it doesn't matter if it's a scanned document or a Cerner-generated document. They're going to be in the same bucket. Because each one is an event code, right? So you can find it, you can put it in the bucket.
Yes. I think some of the limitations we've had on the workflow M page with the documents component is if it's single doc scanned in and it already, let's say it's an HMP coming from an outside office and it's scanned in from the staff, then it makes it look like the signature, the authenticator is not a doctor, so it doesn't show. And when we created those filters in the component, so I was just curious if that problem solved here by this custom M page.
Yeah, we wouldn't have that limitation.
Okay. Thank you.
And I'll just put a question. Have other people struggled with the filtering or not? I mean, is it unique to us, or do other people find that's challenging?
We struggled.
If there's no other questions, I can go on, Brian.
Yeah, go ahead. I think that looks great.
So the other thing, and this isn't unique to Cerner, but the ability to get a patient story is something that's been challenging. It was challenging in our legacy systems, challenging in Cerner. So we decided to look for ways to improve the end user experience, and we ended up contracting with a company called Wellsheet. And I'm going to now, got to get back here. I'm going to just pull up. So I'm on the same test patient here. So some of the stuff may not make sense, but they put in information for me, so we'll have something to look at. The Wellsheet, too many clicking here. So the Wellsheet creates a view that's basically, I think, generally more intuitive to people. So on this patient, you can see there's a quick view over here, and you can quickly see, you can get to information, and it's put in a way that you just can process the information more quickly. For instance, the Fishbone Labs here is just a really easy way for people to process information instead of scrolling through a list. And if you go down here, you can see that there's other things, including meds, documentation, and you can click into these and pull them up. I will give you the caveat. We're finding that the load time to pull up this document is longer than we'd like. It's taken about 20 to 30 seconds, which people don't like, but you can pull it up. But you can see that you can actually get to information pretty quickly. There's also an all view, so if you want to see things that were filtered out, you can see it there. So that's the kind of the quick view. And then on this, in the middle here, is the storyline. And the storyline gives you a reverse chronological picture of what's going on with the patient. And what's really cool about this, in my opinion, is if I hit all here, you can see you can really trend things over time in a really much more efficient system. From my perspective, it's way easier to see it. And on the medications, what's really nice is you can actually see, this is kind of the MAI, you can see when it was administered if you hover over this. So it's a pretty, again, a lot easier than the clicking around that the hospitals had to do to find their informations. And again, if you go down, there's other information you can explode down here to look at it, and you can, again, do some trending. So this was our attempt to really start to use this functionality to create a more useful way for people to find information. So there's the storyline, and then the final thing is the workspace is kind of a work in process, but you can actually do some cool stuff here. So you can potentially add, let's say, put anti-infectives there, just add that, done, and put in your workspace. And you could trend that against like a temperature. So you can actually create your own workspace to basically follow a condition. Obviously, this is a simple example, but you could trend glucose against insulin dosing. You can trend weights against LASIK dosing. You can create your own workspace for actually following patients. So we think that this is a pretty good product, and they're iterating it pretty much on a daily basis for us. One of the things I'll point out is one of our challenges has been managing observation patients. So what you can see here is they actually have an indicator. No, this is a test patient, so it doesn't make any sense. But if the patient is in observation greater than 12 hours, it will change color. If it's greater than 24 hours, it goes to this pink color. And it's a way to help the hospitalist know where their patient is in terms of the time they've been in observation. But it also will show you length of stay as well if it's an inpatient. And there's indicators here. So if I have new results, you can see that there's new results. So there's a total of 15 results I haven't reviewed. 2 of them are abnormal, indicated in red, 13 are normal. And if you click on it, it just pulls up the values, and you can just view them if you want. And you can manipulate them as well. So we have, this is the patient story Wellsheet. We're also working on it. If this patient has COPD, there's also a disease-specific Wellsheet we made for COPD, which is able to pull in CAT scores, spirometry results. It shows meds by class, and it will show LABAs, LAMAs, and all the stuff that you're trying to do to manage the COPD patient. So we're working on that currently, and that's actually in production now. So did the patient story was the first one. COPD is our first disease-specific one. I'll stop and answer questions if people have any.
What was the implementation timeline like with Wellsheet?
Well, it was supposed to be about 12 weeks. It was longer because our original setup with the API was not built correctly by Cerner, so we had to redo that. But from start to implementation was probably about 20 weeks. But it would be shorter if your API is set up correctly.
Okay.
I was wondering if this was a Smart on Fire application, but...
Yes, that's what this is.
Thank you so much for presenting this. So I'm just trying to use, when you said you did the COPD, or you're starting to build disease specific, why did you choose COPD?
It's an initiative at our hospital to reduce readmission.
Okay, for readmission. So 5 major conditions you'll be following, do you think? COPD, STEMI, and stuff like that?
Yeah, I think and the way Wellsheet works, it's only going to show you a Wellsheet if there's that condition on the problem list. So unfortunately, this is a test environment, so I can't make it as robust as I wanted to. But what I've done right now is I've launched the web browser version of Wellsheet, and this actually would be my whole patient list here. So from the web browser or your phone, you can actually get to the same information. Just going to have to log in. I was out for a second. So you can actually get into the same information through the web browser or the phone. And the hospitalists really like having their list of patients on the phone, and they can actually look up a lab result on the phone. They also can do something really cool. They can send a notification. So if they want to be notified when a lab results come back, they can actually do that at the time they place the order. So they can actually, it'd have to be a new order. Let me see if there's one I can. Yeah, so if I want to be notified when this result came back, I would now get that notification to my phone. So
Thank you for that. Well, I guess I have one more question. This,
yep.
I'm saying, can be used in so many ways. Have you thought of using this for your readmission? So when a patient comes in, maybe discharged from the hospital we have 30 days, but maybe 15 days. Could you use this in your ED? Is this just for the inpatient, or would this work with FirstNet and so on?
Yeah, our ED is actually one of our heavy users of this. So it works in any environment. We're actually rolling out to ambulatory in the next 2 weeks.
So how do you use it in the ED?
So the ED they pull it up because they like the patient's story. They really like being able to see the fishbone labs and to see what documents are back. If they send something out, they can click into it, and if it's a consult they're waiting for that came to the ED, they could actually go in and just pull it up from here. But they like the ability to process the information quickly, so they just kind of like that view.
So, like you see, you have the orders, not orders. Well, I guess those are lab results. When they come in, would you say in the ED? Is there a way you could set it such that this is a patient that has been readmitted in the last 15 days, or just tells you this patient is one of your patients and has been readmitted?
I mean, we haven't done that, but it definitely would have that capability. They would be able to do that, yes.
Thank you.
Yeah, Paul, this is Dan Duzan. There's so much, to have those labs be able to be pushed out, there's so much, I'm just thinking of all the opportunity. You're thinking of a lactate in the sepsis cases, or troponins, or anything where you could actually quickly, get actionable information. That's just a great tool in and of itself, that ability to kind of have that push on those labs. So thank you for sharing that.
Yeah, and what we're doing, the limitation we had with the notifications where people had to sign up to them is sometimes, as you know, it's not clear who's responsible for the lab. The ordering person may be off or gone or whatever. So we actually now have developed a patient list with them. So for the hospitalist team, we'll know who's assigned to that patient. So we're going to set up notifications that automatically go, so you don't have to sign up for it. So I think the example you gave would be one. Lactic acid would be one would just want to push. Probably MRI results, CTs, consults, with stuff that would make you manage that patient differently if you knew that information was back. Because as you know, it's so inefficient because you have to keep going back in to see if a result's returned or consult's done. So we think the notification feature is going to be great. Now that we're going to have these patient lists, we're going to be able to have the assignments correct to make sure it goes to the right person.
Are there any other questions about Wellsheet or for Paul? Stephen, did you join from RWJ Barnabas? So another user of Wellsheet who's also part of this roundtable is Dr. Stephen O'Mahony of RWJ Barnabas. So if he had anything else to add, I would...
Well, he's the guy that convinced me to go with Wellsheet.
All right.
They have a pretty cool initiative they did with CHF, and they were able to proactively identify potential candidates for TVAR, just pulling clinical information from the chart, and they made it easy to enter in consults and stuff. It was a pretty good use case, and they really got appropriate enrollment to the TVAR program because it was able to read the ejection fraction off of the echocardiogram, which is, just think about how impossible that is now, but that Wellsheet can actually do that because they can scan an echo report and pull out the EF from it.
Great. Paul, anything else that you wanted to review or cover?
Nope, that's it.
All right. Well, thank you for kicking us off with our new initiative here this way.
Thank you.
Appreciate it. Dr. Halford, we will move on to you, Covenant Health and your sepsis optimization initiative.
Thank you, Brian. Let me just share here and you let me know.
Yep, I can see it.
Can you see it in the presentation mode now?
Yep.
Okay.
I think, right?
Oh,
no, we still see the menu.
It's not in presentation mode.
Let me go back here real quick. Now you should be able to see it in the presentation mode.
It's really big. We only see part of Covenant. It's like maybe a quarter of
It's
the
zoomed
screen.
in for some reason.
Yeah.
Well, maybe we'll...
Presentation mode better.
Yeah, if you just want to leave it in the mode you had previously, I mean, we could still read it that way.
Okay, will do. Sorry about that.
Nope.
Okay, well, Dr. Clark, that's a hard act to follow. Thank you for kicking us off. I agree that was very beneficial. For those of you I haven't met, my name is Mandy Halford. I'm the Chief Medical Informatics Officer at Covenant Health in Knoxville, Tennessee, and went back and forth on a couple of different topics that I wanted to share with the group, but I landed on sepsis optimization because I'm sure many of you are working with your quality and patient safety departments on how do we continue to improve the EHR to fully meet the SCP-1 quality measure. And we spent a lot of time on this last year, but we still have additional optimization to do this next year. And as you know, the journey always continues for this topic. So Dr. Dan Duzan is on the team with me as well, so he's on the call, and he's been a big champion for us, so he may chime in today as well, and you can address questions with both of us. So in the introduction, the reason I did a PowerPoint today is because I'm just going to show you content from a lot of different physicians, and I thought it would be hard to demo as an ED nurse and an ED provider and a hospitalist, et cetera, et cetera. So I hope that will be sufficient, but if we need to get in and live demo some things, we can do that as well. Just to level set, Covenant Health does use Cerner's Performance Excellence tools for Sepsis Advisor. Just, out of curiosity, how many people are using those tools today?
We're using the Sepsis Advisor also.
Okay.
We are here in Miami. We're using it as well.
Okay.
UT, as you know, but we're not.
Thank you, Clay. In addition to the Sepsis Advisor, we did build power plans that have some content for sepsis. And then our current design is we do have alerts going to the providers for both severe sepsis and septic shock. We have 3 levels of alerts built: sepsis, and then severe sepsis and septic shock, but we only send the severe sepsis and septic shock to the providers. I thought I'd start from the ED. As many of you know, you probably had to work pretty hard to determine what's the best way to pick up on this early on in the ED, and we built some custom documentation in the ED triage note for the nurse to, first of all, identify, does the patient have sears, and then do they have a suspected source of infection? And if they have a suspected source of infection with sears, then the nurse is guided, and we have a policy that approves these orders, that they are guided to begin an ED nursing suspected standing order set for sepsis. And this is just a screenshot of what those orders are, mainly just the diagnostics and to get the ball rolling on the IV and those labs. We do utilize LaunchPoint in the ED for providers at this point. We do not have that on for nursing. Nursing is using the traditional tracking board. And so we worked hard there too to really put some color and wording identification for when these alerts generate. The SEERS alert, severe sepsis, and septic shock came with Cerner's tools. And so we didn't have a lot of custom work to do there. But in here, you'll see the sepsis triage in gray. We did have to build custom work to go into LaunchPoint if a nurse was to identify and triage that a patient had suspected sepsis. And so that color indication is a lot of what the providers use to help them risk stratify the patients. And then of course, we've got the traditional icons for vitals and for labs that they're looking at as well. In the beginning, we've had a lot of, number one, in hindsight, we're only about a little over almost 2 years live on the system from our first hospital. And so we went live with the sepsis advisor and BTE advisor at the time of implementation. And in hindsight, you know, that may not have been the best approach. It might have been better to go live and then come back and add these on as optimization. But there was a lot of feedback on these alerts and how they work, et cetera. And one of the feedbacks that we received is the way it's set up in Cerner is really for it to be more of an open chart alert for awareness. So as soon as the attending physician or the ED physician opens the chart, that you're aware that the system in the background has identified this as a probable severe sepsis encounter. And on the severe sepsis alert, it really just gave 3 buttons. One was to just defer the advisor, and that just made it go away, and it never came back for this time that you're in the chart. The second was to launch the sepsis advisor, which is really too early in the workflow to place orders because you haven't even had a chance to review everything yet. And then the third button was sepsis not indicated. And again, really at that point, the provider's not had time to review. So one of the most recent enhancements that we put in, and this did require custom work from the team, is to change that defer advisor button where it doesn't just make it go away and let me move on, but once the doctor is in orders, which we felt like was really the sweet spot in the workflow, then it adds that sepsis advisor to their scratch pad so that then they remember, oh, the system did say this is a potential severe sepsis and septic shock, and I'm prompted to walk through the advisor and address the appropriate recommendations and orders. And we can talk a little bit about that as well. Yes.
Can I have a question? It's Clay. Can I have a question about that? So what if they just are chart reviewing but don't actually go into orders? If they try to close the chart, does it say, you know, cancel your orders that are on the scratch pad, or?
We added if they're on the scratch pad and you try to close out, then there's another alert that fires on close chart.
Okay, so if you don't ever go to the scratch pad, because if, for example, you're just reviewing vitals and labs before you go see the patient, you'll get an alert when you close.
Correct.
Okay, perfect, thank you.
Hmm?
So I have a question as well. You did ask before you started presenting who all had this. So we, in our health system, we are on Soaring clinicals right now, getting ready to go to Center Millennium. We did build something very, very similar to this because of course, the quality measures we needed to meet. First thing you said, hindsight, you would have probably brought up this advisor maybe later on, not during go live. My first question would be, how do you continue to monitor your sepsis if you didn't do it immediately? That's one. Then the second thing is you're monitoring severe sepsis and septic shock. The way I understand this, isn't this supposed to be almost like a predictive algorithm we're looking at, not necessarily that the patient is already septic?
Yeah, so we do have a sepsis alert working in the background, but we have that firing to our rapid response team in the facilities to do early intervention, and then they have pathways in which they can contact the provider. We were trying to, if you can imagine, severe septic shock is a smaller population, severe sepsis is a little bigger, but then when you cast the net really wide for sepsis, it becomes a lot of alerts for the doctors to deal with, and so that's the workflow we decided to use.
Okay, thank you. I totally understand that.
And back to your first question, I think the reason I said that is, for us especially, we came from Horizon Clinicals. So in Horizon Clinicals, we basically only had drug allergy alerts. The doctors weren't used to a lot of active clinical decision support. And so now we moved to Cerner, and there was so much for them to learn. There was such a huge learning curve, especially when it came to dynamically reviewing the chart and documenting at the same time, and the difference in how the order sets worked, et cetera. A lot of the go live scars are kind of wrapped around the nuisance of these open chart alerts. And we had both sepsis and VTE set as open chart alerts, and I don't think, they're just not in the right spot in the workflow, and we're still going to continue to work on where they need to go. And of course, we are really interested in looking at Cerner Smart Zone. I know Dr. Callison and others are interested in that for this year as well. But that's kind of why, in hindsight, I wish we would have rolled it out and then really had just the order sets to care for sepsis patients. I would have still monitored it through our quality measure abstraction, even though that was not as real time, and then came back to this a couple of months later.
Understood. Thank you so much.
And I think, to echo Dr. Halford's point, the learning curve to learn to use both the sepsis advisor and the VT advisor were both pretty steep. And so there was just so much information coming in everyone about learning to use Cerner that, it just takes kind of a focused use on those advisors to go through the steps to get them to flow appropriately. So a lot of people got frustrated with that and would just cancel out, right? And so, again, it's one where, looking at, I like what Mandy said about the scars of go live, because that was one of those where it's like, how do you undo that once it's already out of the box, right?
Right. I totally get it. The difference between where you were and where we are is that we've been actively using our own home-built sepsis advisor based on Cerner's sepsis advisor. So I understand it. It could be a nuisance and very difficult learning curve. Thank you.
Yeah, but it sounds like you're in a better place, so hopefully it won't be so tough for you. I'm going to move us on because I know there's a lot of content. One of the struggles we had with advisors specifically in the ED is because, as many of you know, the fluids are 30 mL per kg, we needed the height and weight documented. And so that the doctors were really struggling with open this up, and now what do I do? And so we put a link to the power form for height weight into the advisor, and then re-educated the emergency medicine physicians that if you, for some reason, got to the patient ahead of the nurse being able to document, then you could document height, weight. And then we also had some additional things to do on rules we had IV fluids in our regular rule for meds to stop you if there's no weight entered, and so we had to go back and optimize that rule as well. Within the sepsis advisor, many of you who are using this will be familiar, but it starts with just a review of the patient's current condition, and this is seen to be very helpful for the providers, but it also is just a little busy, and so we needed to do some re-education of this section as well, but not a lot to do here, just really review. In the next section is for you to choose that suspected source of infection, and we've set it to select up to 2 sources, or you can say patient displays no signs or symptoms of infection, and then that will kind of close out the advisor and no need to move forward. If you choose, let's say, pneumonia and urinary source in this case, then the antibiotics behind the scenes flex based on the source of infection. One of the hard parts for ED is in this middle section, the special dosing recommendations. It's, not defaulted to single dose, and so the ED needs to go in and change this to single dose because this advisor works for both ED and inpatient. And as I said before, there's 660 scenarios behind the scenes suggesting the antibiotic regimen that shows. So as you can imagine, this was a difficult design in the beginning to set up. It's not been a huge challenge for maintenance moving forward because there hasn't been a lot of clinical changes in treatment, but we have had to make some changes to antibiotics over the past year or so. The next section is the fluid therapy, the bolus amount, and then diagnostics. I think this is pretty self-explanatory. And then the last section really just gives you an overview of did you check off on everything, and then it does have the ability at the bottom, and I'd like to push Cerner to add this type of functionality in other places, but you can add severe sepsis to the diagnosis list, and so when you sign, it goes ahead and sends the diagnosis out. But that, as you can see, it's very small at the bottom, and it requires a checkbox, so that also is something that really needs to be honed in on education. So we mainly push the advisor to be used the first time in the ED, but then the patient transitions to inpatient, and if you're the hospitalist or intensivist admitting these patients, we have 3 routes in which you can order the advisor. One is you can launch the advisor directly from the alert, which I already showed, and that really is more the least common workflow. The second is you can pull up power plans in which we've embedded the advisor. So we created really just a shell power plan. Our naming convention for power plans is HOS is all the hospitalist content. So HOS, severe sepsis admission with advisor, is really just some general admission orders, code status, etc. And then the bulk of the orders for the patient is in the advisor. Critical care, general, ICU admission has a lot of ICU content, and then it also has the advisor present. And then we also did an alias for the hospitalist severe sepsis, because as you all know, in single order entry, when you're searching, we had a lot of people searching sepsis instead of going to the route of using their quick orders page or looking for the hospitalist content first. And so we just did a separate alias to make it easier to find, but this is really the same build as this first option. And then you can always just pull up the sepsis advisor from single order entry, but that one also was an education point for adoption because it does not have the pizza box because it's not truly a power plan. And so the doctor's eyes aren't pulled to it quickly to plan to order it. One of the things we struggled with a lot, and we're continuing to work on optimization, but if I am the hospitalist admitting the patient, I needed an easier way to be able to tell what has the ED physician done, and now what am I going to continue? And so we did educate on this basic functionality of the merge button to be able to see, obviously, active orders while you're placing new orders. But in the beginning, we didn't realize that related results could also be tied to a power plan. And so we only had that there for meds. And if you're like we are pretty close to Cerner's model design on that, and didn't spend a lot of time in designing what are those related results tied to a medicine. And we have an ongoing optimization for that in general. But in dealing with all of that, we realized that you can also build these related results and connect them to a power plan. So if now a doctor places any of these power plans, because at times they may use pneumonia, for example, and the patient may still be septic, then on the left-hand side, related results will pop up for vitals and lactic acid and all of those things we would be looking for in the septic patient. I will say that that's helped somewhat, but ultimately we've got to do a better job at giving them a one-stop shop, and I think the quality measure component is going to be that for us, and I'll talk about that in just a couple of minutes. Any questions on this related results or how we set that up?
I just have a question. We did we had to also relaunch our whole sepsis advisor after go live. Nobody used it because of all the things that were said, and we relaunched the whole effort. But one of the challenges we had was getting the right fluid bolus, and I was just wondering if you had that problem.
We're better at it now than we were, but I mean, it's always a challenge. I think one of the things that we've had to hone in on is, especially, and we're still working on some optimization here, but especially in the population for morbid obesity with a BMI over 30, you can use the ideal body weight for calculating the 30 milliliters per kg. And so we've been trying to work on how do we make that ideal body weight more easily viewable for the ED providers as they're determining. And then, of course, just as you know, I mean, Dr. Callison, as pulmonary critical care, obviously knows this very well, but for an ED provider or for me as a hospitalist, sometimes we get a little bit nervous about giving that many fluids. So we had to do a lot of education and re-education with our intensivist champions on this is the right thing to do. And, you know, the fluid overload and those other side effects we can manage.
Well, specifically what we had is the hospitalist didn't know when the advisor came up, they didn't have any visibility of how much fluid the patient already received.
Yeah.
And that was a big challenge. The only way I'm just curious what people did, we ended up taking it out and made it a nurse protocol driven order so that they follow the recommendations. Because when they transition from ED to inpatient, it depends who touched the advisor last if they ordered the right amount of fluid, and we just ended up having to take it out.
This is Sandy O'Laughlin from Concord, too. I joined the call a little bit late, but just to add to what Paul just said about the nurse-driven protocol, we basically went that route. We have the provider calculate the total based on the 30 milliliters per kilogram and enter a total volume, and then the nurse is able to look at what was given potentially in the ED or pre-hospital, and then calculate what's needed to complete the full 30 milliliter per kilogram bolus, and then order anything additional. And that seems to have actually gone quite well, and I think patients are achieving their total sepsis fluid bolus better than they were prior to rolling that out.
That's great.
Yeah, we felt that it was just too difficult in the advisor. When a hospitalist would order it, it wasn't taking into account, as Dr. Clark said, what they had already received. So either we ended up ordering too much fluid, or providers weren't ordering it and then going outside of it, and usually not ordering enough and falling short. What we did teach to in our organization too is with the sepsis population, we're not really as concerned about the CHF complications because that's the perfusion need. And so we're really trying to be more aggressive with getting the full 30 milliliters per kilogram in.
Thank you.
Sorry to jump in. I joined late, but I'm definitely interested in the sepsis conversation.
Absolutely. Well, and I'd love to connect with you more on the nursing protocol. One of the things that you all, I'm sure, are familiar with is the reassessment, the language and the quality measure change, where really just documenting sepsis reevaluation was performed counts, where previously we had to document physical exam and passive leg raise and all of those items. And so we created a simple dot phrase, and it is tied to a voice command to help the providers remember to put this in their notes. As far as other optimization efforts, I'm sure many of you have had discussions about lactic acid and repeat lactic acid. We traditionally at Covenant have had more of a sepsis lactic acid with reflex and then a non-septic lactic acid. And we had a lot of discussion over this past year. Are we just going to move completely to all lactic acids reflexing? We spent time going out and looking at up-to-date and other evidence-based literature, and really from my review and our team's review is the literature really still supports having a lactic acid with reflex and one without. Really, if you're looking at those post-surgical patients and other things where their lactic acid is going to be elevated for an extended period of time. The big problem for us on this is we had lactic acid built naming convention just as lactic acid, and then the sepsis lactic acid that does the reflex naming convention as sepsis lactic acid. Well, as you know, in one-off orders, it goes alphabetic order. And so there were lots of times, even though we had hardwired things in the ED for all lactic acids to reflex, there were still people who were going out and picking the regular lactic acid. And so we redid our naming convention, and now the names are lactic acid with reflex and non-reflex lactic acid. And that pulls the lactic acid higher up on the list. And that's really, that along with some of the automation we put in the ED has really solved that problem. There's also, as I'm sure you all know, if you use ED boarded beds, just some workflow optimization we needed to go through with that as well, as far as timing of orders, et cetera. I kind of already went over the rules, but again, we will continue to work on optimization. We added that defer button, but now our next steps will be focusing on the smart zone or timing of the alert. Does it continue to make sense to do that as open chart, or is it better to do it at a different time? On the advisor itself, as I mentioned earlier, we still have some custom work to do with getting that ideal body weight included and additional logic on calculating with the ideal body weight for fluids. And then one of the big areas that we're really honing in on is that quality measure component. And this is a lot to dig into. I don't know how much time you all have spent in reviewing the build for this or in optimization, but for us, the way this works in the background is if the nurse in triage enters 2 sears and a suspected source of infection, or the provider selects a source of infection in the advisor, it fires a rule to order a quality measure sepsis order, and that quality measure sepsis order populates this section of the quality measure component. And then that component split out by incomplete activities and complete activities. And there are action buttons, which are nice, and I know we're on 2015 code going live with 2018 code on February 23rd, and I know these buttons will change, but the functionality behind the scenes is the same. But because this is a shared component, these action buttons, for example, I'm in as a provider, and this tells me I can collect the blood culture because that's incomplete right now. Well, we know doctors don't ever collect the blood culture, and so how could we change this to make it easy for the doctor to see blood culture hasn't been connected or collected, but really only allow the action button to take you on to either collect or administering meds, only be viewable for those applicable clinicians and not the doctors. So that's what we'll be spending the majority of our time on in the next few months after the upgrade. And our hope is that this will be the one-stop shop that providers can easily see what's already been done in the ED and then what do I need to continue to do, or just a snapshot in general of how did we do with treating sepsis in this patient.
So
Comments
this is Mandy O'Laughlin from Concord. I wanted to jump into on your lactic acid issue. We've had similar lactic acid issues, and it probably would be a good idea for us to connect. We're currently under conversations again about reflexing all lactic acids over 2, because as you mentioned, the lactic acid that reflexes that we have built into the advisor, people are ordering it either outside of the advisor or before they get to the advisor, and then those aren't reflexing. We think we have a potential decision, an agreement to move ahead with reflexing all lactic acids, but I like your idea of, you know, if we get pushback on that, or if it becomes an issue, having 2 separate orders, because that might help get us around some of the resistance to that.
Yeah, be happy to connect with you on that.
And Sandy, hey, this is Clay Callison at UT. So we had this, I think everybody has the same issue. We have one called sepsis, called lactic acid, and one is lactic acids, sepsis, or sepsis. And for our sepsis bundle, obviously the lactic acid sepsis is the one that fires, and it's a reflex. But that way people, when they're ordering it, even if they're one-offing it, the word sepsis kind of draws them to that if that's the reason why they're ordering it.
Okay, that's helpful.
All right. Next steps for us is continuous collaboration with our patient safety and quality department on re-education and process improvement. And then the other thing we want to do, I think earlier you asked about data. We are looking at data on how many times did the alert fire for severe sepsis and septic shock versus how many times was the advisor utilized versus sepsis being documented versus how did we perform on SEP1. So we'll continue to do a deeper dive on that this year. We, in general, I think do see that when we use the advisor, we do a better job at meeting SEP1, but we really just need some more dedicated time to go through that data on a deeper level with the team. And then just
based quickly on your analytics there. So like I said, ours is a homegrown solution, but pretty much like what you have just presented. One of the things we've had challenges with would be just people using the 3-hour and 6-hour bundle. One of the first questions would be, this patient did not, or pushback would be, this patient did not present like a sepsis case, so we did not select we call them order sets, not power plans, but and so you can see how that may just totally be missed. And so where we've been having our fallout is that maybe people are not really using the 3-hour, 6-hour bundle. And so we created an audit for that and tried to push that to nurse managers and so on. I'm wondering how you are trying to document even the use of the advisor and your power plans that are attached to them.
Yeah, so right now we're really just looking at the raw data as was the advisor used, regardless if it was used from the alert or from a power plan or pulled via one-off orders. because we kind of theoretically got to a point as we don't really care how the provider got to the advisor. We just want to know that the advisor was used. I do think that's another way that we could dice the data to say what is the way in which the advisor is being pulled, and does that help us even optimize the workflow further?
So we are collaborating with our quality department, and one of the asks for my team is we may have just 2 or 3 fallouts and with severe consequences, like the patient might die and things like that. And then, of course, you go back, audit the chart, and then you start to look at the advisor. Did they use it? Did they miss it? Did they use the order sets? And that's how we got into actually having a routine audit of this. So I'm just wondering, from what angle are you looking at this? Is it just based on the implementation and the use of it, or are you actually connecting it to your quality measures?
We're actually connecting it to our quality measures, but when it comes to acute hospitals that are on Cerner using the sepsis advisor, we're talking about 8 hospitals, and so looking at that data, we really had to look at it from more of an analytics perspective. However, our local facility quality managers are reviewing 5 cases a week for fallouts and then escalating things to us. And what we're getting ready to do is go through an overview of some of the highest trends from the 4th quarter with IT involved in that chart review, to your point, to take it down to the next level.
Thank you.
Mm-hmm. And I'll just end on the journey continues. As we know in healthcare, the quality measures always change. It always gets just a little more complex. And I know that this will be an item we will be working on for the long term, but hoping to make additional progress this year. So if you all have any other questions, I'm happy to answer it, but I think I'm a few minutes over time.
Yeah, are there any other questions for Dr. Halford?
Thank you for presenting such a complicated functionality, I guess.
Absolutely.
And when I send out minutes, I will include this slide deck that was just presented, so we'll have that as well.
Thanks, Brian.
No, thank you. So we do have some time built in, just sort of for open discussion. So outside of Paul and Mandy presenting, I just wanted to make sure that if people had any questions or items that they wanted to bring up, that we had an open forum. So since I'm here in the room with Christy and she raised her hand, I will let her go ahead and go first from Northside.
I just wanted to ask the group where we felt like we were with our MedRec initiative with Cerner. I know we presented them the document, they gave us answers. I don't know if we ever decided, did we want to try to get them to come to a meeting, or maybe somebody?
Yeah, actually I have an update. So there's, I think as you all know, there's been some reorg with physician leadership for Cerner, and so it's kind of odd because we're a nonprofit organization, but we officially fall in the IO group, and our current Cerner Chief Medical Officer is Dr. Walter Kerschel, and so I've had multiple conversations with him about the response that Cerner gave back to us on those top 5 MedRec issues, and he is agreed that Cerner would be happy to join us on a call and include Francis Wu. And he would like to have the opportunity for Cerner to share the roadmap on MedRec with us for the next year, and then be able to address those 5 issues that we talked about, and then perhaps some open discussion. I looked at the schedule, and I think March is probably pretty busy for lots of people, and I think our next call is April 8th, and so I was going to ask the group today if that was the most appropriate next steps, is to invite them to our April 8th more open discussion call. Brian, was that okay with you as well?
Yeah, absolutely. Because we didn't really have anything teed up for that, so I think that would give us a chance to make sure that we had the ability to make that meeting. I think it'd be good if we had maybe one or two people sort of present the top 5 items, so we can kind of have that laid out for them, but really use that hour so we can all sort of have a united front, a united voice on those 5 items that we've described.
Mm-hmm.
Yeah, we're happy to help in any way we can.
I agree. I think that's great. I mean, at UT, we're working on MedRec this year, both from a technical aspect, but really more from a qualitative quality aspect. And so I think it'd be really helpful to see what Cerner has to say.
Okay, well, I will reach out to him and see if we can get things confirmed for April the 8th, and then I'll just be in touch with you, Brian.
Yeah, that's great. And then we can, I haven't sent the invite, but probably right after this meeting, I will go ahead and get that sent out to all of us so we can make sure that we can clear our calendars, because that'll be an important one to make sure that we have as many sites join as possible.
Yeah, we probably have almost double the amount of hospitals now on these calls than when we sent that, so we might even be more impactful.
Yeah, I was actually running some of those numbers earlier, and you're right. I think we're probably up to about 40 to 45 total hospitals and close to 20,000 beds, and
So if
I
we
mean,
could add
10,000,
more
20,000
Yeah.
physicians. Yeah.
If we could brush up that document and add more names, and I think we also added an item or two after it was sent to Cerner, but just for tracking purposes. So maybe we could just dust that off and circulate it around the group.
Yep. Yeah, I want to make sure that everybody kind of has given their permission for the names to be used. I think everybody that's on this call, for the most part, has been okay with it, but I just want to make sure that I kind of get that in writing for this.
Sure.
Dr. Halford, thank you for taking the lead on this. I think this is big. I know that's a lot of work for you to go and do.
Yes,
Absolutely, no problem. It's important.
Yeah.
Any way that we can help or share the burden, let us know. We're happy to.
It may actually be good from a Cerner non-investor-owned perspective, so maybe we should take that up through the other routes within Cerner, because I know Dr. Kerschel is only over, I believe he's only over the investor-owned, isn't he, Dr. Halford?
Correct, and then Dr. Lewis, with Chris Lewis is, I can't remember what the division's called, but the other division, because Jigger moved to the VA. Dr. Patel moved to the
Lou D'Souza would be the person. Dr. Lou.
Okay.
She's overall.
Okay.
Except where Jigger is.
Okay, so I know both of them. I can reach out to them and just say that they may want to get with Dr. Kerschel. I have already talked with Dr. Lewis about this before, so it wouldn't probably come as a surprise to him. But I can reach out to them. I think it may be important for them to join as well, just so they're all hearing a consistent message, since we do cover both those different groups within Cerner.
And what about Dr. Wall? Where does he fit in with this? Because I know he's over some strategy stuff too. But we can figure out.
Yeah, we can figure out who all should be invited.
Okay.
Yeah.
Well, I think Dr. Kerschel was going to try to see who was the most appropriate from the development side that should be involved.
Didn't Wall take Doug Dickey's spot?
That's my understanding.
Yeah. Dr. Wall would be really, really good to be on this.
Okay, so we'll take that as an initiative to just figure out who all should be invited. We've got a couple months to get that together. Anybody else have any items that they want to talk about, or that they may want to tee up for a future meeting?
Ryan, I just wanted to say, if you need help, I volunteer help for the providers, the physicians.
Okay. Great, Tino. Yeah, I know you know all those, all of them, so probably where they are today, too.
Yeah.
So thank you. I'll probably reach out to you.
Okay, thanks.
Couple other items that I had, more housekeeping items. if you noticed in the meeting, I did say that we're starting a CMIO Roundtable, so a nursing counterpart to this meeting. And we previously have had some of the CMIOs or nurses join this meeting in order to just kind of hear what's going on, but we didn't really have a quorum to be able to have that meeting. But I think there's enough nurse leadership that we're able to get from the facilities now that the first meeting for that's going to be March 4th from 1 to 2 Eastern. So the invites have been sent out to the CNIOs that I have right now. But if you have a CNIO that you would like me to invite or a counterpart on the nursing side, please send me their information and I can make sure I get that to them. But I think I've got Northside, Concord, Covenant, UT, a couple others in there. So if you have somebody there or you know a nurse who would like to be a part of that, I think that'd be great. But they can join. We're going to try and do the same format for them moving forward. And then, so we'll sort of alternate between the CMIO and the CNIO forums. And so from a meeting perspective, April 8th, we'll have our meds reconciliation discussion with Cerner. And then June 10th, we'll be back to this format with the innovations session. So I was going to have Sidra Health present. He's not on today, but I think I was going to see if he would talk about some of the reporting measures that they do and how they track reports with some of the tools that they use. And I'll put you on the spot, but Dr. Callison, would you be willing to be the other site to talk about innovations on June 10th? You may have already.
He's on mute. I'm just kidding.
All right. Well, if he says no, I may reach out to the group and see if anybody else would want to volunteer to do that out in June.
Brian, this is Paul again. I had to jump off for a few minutes back on. I'm also very interested in the med rec, and I really think we need to push meds by class big time to Cerner. So that's my 2 cents on med rec. But just letting you guys know, we're going to be an early adopter for intelligent patient lists from IMO. It's going to be another API. There's one Cerner site currently testing it. I think we're going to be the second, but it's well used in Epic. But it gives you abilities to document HCC coding and drive specificity that we can't get out of Cerner. So we'll be implementing that. Probably wouldn't be ready to present anything to maybe the fall, but we're pretty excited about it. So that's just FYI.
Paul, what was the name of that again? Sorry, I didn't get that.
It's called IPL. It's Intelligent Problem List, and it's a functionality of IMO, but it's another API. It looks like it's in Cerner, but it's actually another one of these Smart on Fire standards, and it groups diagnosis by you have cardiovascular disease, endocrine diseases, pulmonary diseases, all grouped. You can easily see if there's duplicate diagnosis, easily can remove them. But what it does is it has indicators if it's an HCC code. And as everybody knows, you have to document on those once a year. So it looks like it's got pretty useful functionality.
Great. I took a note on that, and maybe we can.
That'd be amazing to follow because we probably are all still struggling with provider problem list. Mm-hmm. And searching.
I was on a call with Ryan Murphy. He's the owner and Cerner of that application, and it's nowhere in their vision of that being improved. So it is what it is, and they're the ones that push me to look at IMO.
Interesting. We're trying to get a call with Ryan as we speak, so we'll definitely take what you said into account and ask about that.
I'd ask them because they fixed one problem for me because they couldn't even the way they were trying to specify hypothyroidism. their little algorithm actually didn't get you to the most common cause of hypothyroidism. So they actually fixed that, but they have no bandwidth or interest in actually iterating that module.
Okay, that's helpful, thank you.
And again, can you say the product one more time? I'm so
Yeah,
sorry.
sure. It's called Intelligent Problem List, IPL. That's the name of the application. And I don't know, I assume you're familiar with IMO, but they're the engine behind all coding. So I've worked with them in the past in our legacy systems. They're pretty good to work with. They're very knowledgeable clinicians that work there. They're on site actually here yesterday. But their product is pretty awesome. And if you go on the AMDIS listserv, there's a whole string from APA customers about this application. So you can get some an interesting thread in there.
And the company is called Intelligent Problem List? Or?
Well, IPL is the application, but it's Intelligent Medical Object, IMO is the company.
Oh, the IMO owns this. Okay, got it.
Yeah, it's an IMO developed application.
Yeah, you can just go to imohealth.com.
Got it. But it's been approved by Cerner.
Yeah, there's one site currently in California that's trialing it, and I believe we're going to be the second site.
Dr. Clark, I'd love to continue to follow up with you. We looked into it because we were having some challenges last fall, and we demoed it to our primary care physician leadership group in January and decided to hold off for right now, only because, and I can't get a good stance from Cerner on this, so I continue to push them, is their strategy to move forward on advancing the problem list, or is their strategy to move to IPL? Because IPL is great for searching the terminology and for getting those secondary diagnoses that we definitely need in the ambulatory space. But then you have to go back to the problem list component to prioritize to then move on to your assessment and plan. So right now, our primary care physicians really felt like they were excited with the search capabilities, but they felt like at this point it seemed more like duplicative work. So they just want to monitor it closely and then consider implementing it later this year. So I'd love to continue to hear posts.
I'll definitely let you know, but the way it's integrated, it's not duplicative work. You never touch the problem list again. You manage it through IPL.
I wonder, that's just not how they demoed it to us. I'm blanking on the physician's name.
I'm sure they didn't have it at the time because they hadn't been integrated with Cerner. This is the first site is integrated now. This is the first time they had it. I'm sure they showed you the web-based version, which would be duplicative work, but this is now embedded in Cerner. You won't be able to tell you're not in Cerner because it looks like it's in Cerner.
That's how it looked for us, but anyway, okay.
Yep, glad to get follow-up.
Brian, are we going to have this recording? I know you're recording this session.
Yes, so there is a SharePoint. I haven't sent all the instructions. Christy kind of helped me get it all set up, so I can send the instructions to everybody so you can get out to the SharePoint. I do put the meeting minutes out there, and I will put the recording because I don't think people want a 500 meg file sent to their email. So I will put that out there with the link to it. What I will send through email, though, are the meeting minutes and the PowerPoint that Dr. Halford did. So once this gets generated, I'll stick that out there for everybody.
Thank you.
Yep. I did want to ask. Oh, yeah, go ahead, Paul.
I said thank you.
Oh, of course. I did want to ask the group if anybody's planning on going to either of the Cerner rugs. So there's the Southeast rug in May and the North Atlantic rug in June.
We're going to have people in North Atlantic. I'm not sure if I'm going, but we'll have people there.
Okay. So I think myself or somebody from Make Solutions will be there. So if there is a big enough group, we just wanted to make sure that we could maybe put something together. I think most of the people on this meeting would fall into one of those two rugs. And how about for HIMSS? I know that's coming up in about another month. Do we have folks going to that?
Not anymore.
Not anymore? Okay. I understand. Great. Well, I think I've covered everything. Again, thank you, Paul and Dr. Halford, for your presentations today. I think this was great to be able to hear from you and what you're doing. I mean, I was taking notes. I think this is great. Great stuff that you're doing. So I want to continue that again when we do that in June. But for right now, we'll make sure that our April meeting covers the Cerner Meds Rec discussion. And then again, we'll have the CMIO Roundtable next month, March 4th as well. So, and I will get all this sent out to everybody. And
thank you.
Thanks for making 90 minutes today. We appreciate it.
Thanks, Ron.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Thanks. Have a good one.